my talk today about the abrupt vessel closure, which is actually a very common complication occurs in the cath lab. And I have 3 examples today. Definition of abrupt vessel closure, cessation of the coronary flow to TIMI grade 1 or TIMI 1 flow inside or proximal or distal at least 5 millimeter to the lesion in which PCI was attempted, where flow was TIMI grade 2 or 3 prior to the procedure. If the TIMI flow grade 1 was present prior to dilatation, then TIMI 0 considered TIMI abrupt vessel closure. And if it is TIMI 0 and you got TIMI 2 or TIMI 3 flow, then again TIMI 0, so it is abrupt vessel closure. Most commonly due to dissection, thrombosis, and most often it is combination of both and other causes like neuroflow, spasm, air embolism can causing this abrupt vessel closure. First patient, actually, it is 46 years old, Yemeni male patient, presented with central typical chest pain, 6-hour duration. Upon arrival to the emergency department, he was unstable hemodynamically with frequent BVCs. Suddenly, he collapsed with VF. This is shock given for him, and ECG showed extensive anterior wall myocardial infarction, ejection fraction 35 to 40, troponin first set 0.04, and LDL 4.2. Patient taken to the cath lab, and this is the right coronary artery, no significant lesion, but there is filling of the LAD with collaterals from other side, and this is the LAD, very tight, 99% occlusion. Actually, probably it is revascularized spontaneously. So I passed the BMW wire. It looks for me initially it is a very simple case, then a small balloon dilatation, and this after ballooning of this lesion, then first stent deployed, and this after the first stent, there's still residual lesion distal to the stent, so I decided to use a second stent. And deployment of the stent, immediately this is the after deployment of the stent, there is closure of the artery. Actually in this situation, this is always my practice. I using the gold standard test. I inject distally through perfusion catheter or the expert case or another technique I use, I will present the second case, and inject contrast in this distal to the occlusion site itself. If the flow coming back like this case, back flow is excellent, so there is no dissection in this case. The obstruction is mainly microvasculature. So immediately through the perfusion catheter, I give the medication, the nitroglycerin, adenosine, and nitroprusside, terfeban 500, and this is excellent result immediately after injection of medication more distal in the coronary artery itself. And this is the final result for the first case. Second patient, actually 47 years old, Indian male patient, strong family history of premature coronary artery disease, presented after 18 hours chest pain, ECG Q wave, mild ST segment elevation as anterior leads, troponin 4 echo 35 to 40%, and again this is subtotal occlusion, actually probably late presentation with spontaneous recanalization of the artery. So I'm using balloon preparation and dilatation of this lesion, and this immediately after the ballooning of this very tight lesion. There is abrupt vessel closure. And again, in this situation, I asked for perfusion catheter in my cath lab. I don't find perfusion catheter. It is finished from the shelf. So I, using the same balloon I dilated with, I make multiple puncture, at least 6 holes in the balloon. Then I using the balloon as perfusion catheter distally, and the balloon showing there is no backflow of the contrast. There is good distal flow, but there is no backflow. So it is actually dissection of the lesion from balloon dilatation. So immediately I don't give any medication. Immediately I take the stent, and this is immediately after deployment of the stent. TIMI 3 flow, and there is residual lesion in the proximal segment. I deploy another stent in the proximal segment, and this is the final results actually. Third patient, actually 69 years old, Pakistani male patient, presented to emergency department, markedly agitated with severe chest pain, 3-hour duration, ECG, inferior wall MI with RV infarction, received loading dose, Plavix and aspirin, fentanyl, but suddenly patient have cardiac arrest in the emergency department with VF 4 times within 1 hour, first for 2 minutes CPR, second 12 minutes CPR, third 4 minutes CPR, and fourth 8 minutes CPR, successfully cardiopulmonary, defibrillated and achieving ROSCA, then intubated, mechanically ventilated, and high dose norepinephrine given with dopamine, amiodarone, and patient shifted to the cath lab. In the way to the cath lab, again, the patient arrested in the corridor, and CPR done 15 minutes in the corridor, continuous until the cath lab room. Then again, patient having more 5 DC shock in the cath lab. Total DC shock is 12 times for this patient actually. Then we started the primary PCI for this patient actually. Left system showed no significant lesion, just mild lesion in the proximal LED, and the RCA showing total occlusion of this RCA. Then immediately I passed the wire, patient given 7,000 heparin, and I passed BMW wire. And expert CAS, there is resistance actually. When there is resistance for ballooning or expert CAS, so we expect there is underlying tight lesion in this situation. So I using balloon after that, and this is inflated first, then inflated balloon, and this is what we see. There is underlying tight lesion, and we dilate, but there is another also hazy lesion distal to the first one. So we are not sure at the time, is it thrombus or is it lesion actually? So I, again, using the balloon, it is actually thrombus. But suddenly there is abrupt vessel closure after we dilate the initial lesion. So it is most commonly actually in the primary PCI, 3 to 6%, most common after balloon angioplasty, then after stenting, and 5% causing periprocedural MI, and 2% in hospital mortality. Just 2 minutes, please.
2 minutes, last 2 minutes, yalla.
It is a very important case. Very important case report. This is actually very rarely reported, and I presented before in EuroPCR. So in this situation, I expect there is underlying tight lesion in this patient actually before it is occluded. So I'm using again the balloon for aggressive dilatation of this very tight lesion, which is not dilated well before it get abrupt vessel closure. And of course, this is what we find. The rare reported cases, angry thrombus phenomena, which is massive accumulation and formation. This is before the occlusion. There is no thrombus clearance from thrombus at all. And this is after abrupt vessel closure. There is massive thrombus formation within a few seconds. This is what we call angry thrombus phenomena actually. It is rarely reported cases, and rapid progressive thrombus accumulation within a few seconds in the lesion. And of course, it is actually resistant to the standard treatment of any thrombus formation or high thrombotic lesion. Need to be aggressively treated intracoronary, and especially manual is not effective. So we need mechanical aspiration for such cases. It is reported in some literature by Tobaz and Lippi. It is angry clot phenomena in some literature. So aggressively, I went for aspiration of this huge thrombus many times. There is improvement of the flow a little bit, distally testimonial flow. So I decided to deploy stent, and then after that, again repeated the aspiration with expert CAS and optimizing the waist with NEC balloon. And this is final results, intra-aortic balloon at the end done. Patient saved after 5 days, went home safely. So my final take home message, asymptomatic time is running, so if asymptomatic, there is no need for opening, and symptomatic, medium, large, so we should open the artery. Just last slide of the take-home message, please.
Khalid, last slide, Khalid. Take-home message, last slide.
It is multiple causes actually. So abrupt vessel closure is real nightmares. Maintain guide wire position in a true human is the key for rapid and successful managing acute vessel closure. It is critically initially to stabilize the unstable patient clinically, and abrupt vessel closure, multifactorial dissection or distal embolization, in situ thrombosis, spasm, embolization, distal contrast injection, gold standard test to assess the underlying etiology, and angry thrombus phenomena. It is rare reported phenomena actually need aggressive tackling with multiple intracoronary medication and aspiration. Thank you.
Thank you very much.